Sumanta, any update?
Sapna, are you there?
So Dr. Partho has also joined. Good evening, sir. How are you?
I'm well.
Okay,
How are
fine.
you?
I'm Dr. Das Biswa speaking. Sapna, are you there?
Yes, doctor.
So
I am
my-
there.
Good evening,
and
doctor.
my
Good evening,
audibility
sir.
and visibility, is
So
it
doctor
okay?
is joining in 5 minutes.
Sapna,
Yes. Can you hear me,
am I
sir?
audible and visible?
Yes. You are very much audible and also visible.
Okay, I'm again muting. Fine.
All right, sir.
Dr. Sapna, I'm just following up. Dr. Oyonkor and Dr. Ganesh Shetty is joining. Just maybe by 1 minute is they are
All right.
joining. Okay.
Okay.
Mm.
हाँ सर आएंगे शायद वीडियो ऑफ है ऑडियो
Hi, Sumanta, can you hear us?
Surendra, yes.
Yeah, I think it is already 8:06. Any
Yeah,
update?
I know. Actually, I don't know why he is not able. This Dr. Ganesh is not able to join because he's trying constantly. I don't know.
आराम से बात
Just had
करते
a talk with the doctor only.
Okay.
मैं लिंक मैसेज करता हूँ व्हाट्सएप करता हूँ ठहरो मैं उसको व्हाट्सएप करता हूँ एक
So I think meanwhile we
Just
should
नाम मेरा
start.
मैं इसको चेंज
Dr.
हाँ,
Gaurav sir
let's
also
start.
joined and Dr. Partho is
Right.
there. Similarly, Dr. Arup sir has joined. So I think we should start. Meanwhile, the Dr. Ayan and Dr. Ganesh sir will join the session. Okay.
All right. So we are starting. Am I audible?
Yeah, Dr. Sapna, you're audible.
All right. So, honorable dignitaries.
So Sapna, we'll have to give a countdown to the team.
Alright.
So Dr. Arup sir, are you okay to start? So
Yeah.
okay, perfect. So hi, tech team, we are ready to go live. Requesting to give us countdown so Dr. Sapna can start. Yeah, Nankishore.
नहीं सर मेरा ये जो नहीं घंटे का विषय जो हाँ वही वो ले रहा सर पासवर्ड से डायरेक्टली S21 आता है S21 तो उसमें आता है सर देखिए सर इसमें
पासवर्ड नहीं आता, ये आपका नाम है, S21 नाम है आपका।
हाँ सर
वो कनेक्ट करते हैं ना, तो एक पासवर्ड देना पड़ता है।
नहीं सर मेरे इसमें तो मैं डायरेक्टली पासवर्ड
Okay. Nankishore, are we ready?
तो ये
Yes, sir. We are live.
Okay. Dr. Sapna, we are live. We can go ahead.
Okay. Thank you. So, honorable dignitaries, esteemed faculty, and dear delegates, a very good evening to one and all. I, Dr. Sapna from the medical team, feel privileged to welcome you all on behalf of the entire team at MCure Pharmaceuticals. We at MCure are proud to present Cardio Colloquium, our highly acknowledged scientific program, which is dedicated to exploring the multifaceted landscape of cardiology. So this program serves as a bridge between knowledge and practical application, aimed at equipping us with the tools which are needed to enhance the lives of those who are affected with the cardiac diseases. Now, I take this opportunity to extend a warm welcome to our wonderful moderator for today, Professor Dr. Arup Das Biswas. Our moderator for today is a very well-known name in the field of cardiology, who really doesn't need an introduction, but to share just a few highlights from his long list of achievements. Professor
No
Dr.
parallel
Arup.
noise, please. No parallel noise.
Yes, I think there's some noise coming from one of the attendees.
Then somebody has switched on, already unmuted.
Yes.
Yes.
I have muted. Sorry for the disturbance.
Okay. So, like I said, but to share just a few highlights from our wonderful moderator's achievements, Professor Dr. Arup Das Biswas is a highly respected interventional cardiologist. He is associated with many reputed institutes, including Bellevue Hospital, Kolkata. He has led major cardiology departments. He has served as a vice president of CSI and WBCSI, president of the WB Academy of Echocardiography. He has conducted numerous clinical trials and published extensively in national and international journals. And we welcome you, sir. Apart from that, we have the wonderful panelists. We have Dr. Ayankar. He is with Rabindranath Tagore International Institute of Cardiac Science, Mukundapur. Thank you, Dr. Ayan, for joining. We have Dr. Ganesh Seth. He is with Medanta Hospital, Lucknow. Then we have Dr. Partho Pratim Chaudhary. He is with Mediterranean Hospital, Jamshedpur. And we also have Dr. Gaurav Verma. He is with SMBT Heart Institute, Nashik. So I, on behalf of entire AmCure team, we welcome you all four as the expert panel. Apart from that, I also would like to extend a special welcome to all the delegates who have joined today's program. It is an honor to have such an esteemed audience and renowned experts among us. So let me brief you all on the meeting agenda for today. We will kickstart the program with session on optimal selection of RASI in post-MI patients by Professor Dr. Arup Das Biswas. The meeting will proceed further with the panel discussion where Dr. Arup will drive the discussion. So I will be requesting the audience to put their questions in the comment box so that we would take up those questions in the end. So now I would like to invite Dr. Arup to deliver the keynote session for today. Over to you, sir.
Thank you, Sapna, for the kind introduction.
Thank you, sir.
Good evening, everyone. And I also welcome the panelists. This is a very erudite panel, very well educated. So I'm happy to have them. Let me share the screen. Can you see my slides?
Yes, sir. Your slides are visible. We can go ahead.
Good evening. So we all know that RAS system, renin-angiotensin-aldosterone system, is a very important physiological system uh, that is concerned with salt and water retention and optimization of the volume and BP, etc. But when it overdoes to compensate for certain assaults in the system mean the whole body I'm talking about, when they become overactive, it becomes pathological and that need suppression. For that, I'll just give you an overview of the usage of RASI in the post-MI patients, both in the ACS setting and subsequently, and then the erudite panelist will give their opinion. So we all know that the RASI or the RAS inhibitor system consists of ARBs, ARNI, AC inhibitor, and also aldosterone antagonists have some RAS inhibition effect, and beta blockers, they have also some RAS inhibition effect. So we'll be discussing finally what do the current guidelines suggest. So let's start with ARBs. The AC inhibitor are the first comers in this field, and subsequently the ARBs also stepped in. So there have been many trials since 90s in the ACS setting. Let's talk about Optimal, and that was published in 2002. And what the key finding was losartan 50 milligram once daily versus captopril 50 milligram thrice daily. Just yes, captopril thrice daily, and it was found that there is non-significant difference in total mortality in favor of captopril. That means it didn't reach the significance level, but there was some difference, and the trend was towards captopril. I'll show you further slides on this. Another important path-breaking trial is Valiant, a large number of patients of about 15,000, published in 2003. And what was found? That valsartan is as effective as captopril in patients who are at high risk for CV events after MI. Combining valsartan with captopril increased the rates of adverse events without improving survival. This second line, I think, is very important. That has been the finding with other studies and trials also, that it should not be ever combined, the AC inhibitor and ARB together. That will cause more harm than good. Now, going to the graphical representation of optimal, if you look into the duration of the trial and studies and the endpoint rate, what we find here, the non-significant difference in the total mortality in favor of captopril. Why do we say in favor? Because you find though the p-value is 0.069, it is running just below the losartan curve. That means there is some benefit with captopril. AC inhibitor should remain first choice treatment in patients after complicated acute myocardial infarction, and losartan cannot be generally recommended in this population. The comparator molecule was losartan. Valiant showed that what happened, that if we take three groups, captopril, valsartan, and valsartan plus captopril, the green one is valsartan plus captopril, all these are running almost parallelly. Here and here you see So mortality from any cause and cause-specific mortality were similar in the three treatment groups. The rate of the secondary endpoint of death from cardiovascular causes, recurrent MI, or hospitalization for heart failure was similar in the three groups. So both primary and secondary events were almost similar. But again, there should be a note of caution that this green curve, that is valsartan carfentanil combination, met certain side effects. Now coming to ARNI, that is the talk of the day in heart failure. And ARNI, we all know, has got sacubitril and valsartan. And this fusion molecule, when we are taking this fusion, given the patient is given a fusion molecule, there is a lot of improvement in heart failure. But what does it tell about its use in ACS? Let's see. ARNI following acute myocardial infarction, the primary results of the Paradise MI trial. That will give you a good message in this group. And the patient selection was with LVEF 40% or lower and or pulmonary congestion. So they were high-risk patients with AMI, and the drug was given within half day to 7 days, that is 12 hours to 7 days. The patient selection criteria had to also include another risk enhancer along with this already high-risk situation, age 70 years or more, EGFR less than 60, diabetes, prior MI, atrial fibrillation, ejection fraction less than 30, KILIP class 3, STEMI without reperfusion. These were the risk enhancer along with this. And exclusion criteria is also important. Prior heart failure was excluded because heart failure, it has been already established that ARNIs are very useful. And clinical instability, they were also not selected. And EGFR less than 30, but that means advanced kidney disease, they were excluded. The dose was given 200 milligram twice a day in about 2,800 patients, and ramipril was given 5 milligram twice a day in again about 2,800 patients. Then they were followed up for 23 months. What was found regarding cardiovascular death, first HF hospitalization or outpatient hospitalization or outpatient attendance of heart failure. So that was the primary outcome. These didn't receive or achieve the clinical statistical significance. That means, though you are seeing that the sacubitril valsartan group is running slightly lower than the blue line, that is ramipril, there is no statistically significant finding. So regarding primary outcome, we found almost a similar effect. If you look into the other components, that is CV death, heart failure hospitalization, outpatient heart failure outpatient heart failure, then there is, at all level, it is insignificant. But if you look into outpatient heart failure, probably it could have run into a significance because it is narrowly missing. So maybe had the number been more, it could have received. But conjecture is not allowed when we interpret trial data, but it narrowly missed the bus. Now going into the adverse event, again you find that regarding hypotension, this was slightly more with ARNI compared to ramipril, 22% versus 28.4%. Cough was slightly more with ramipril. So again, there is no justification to go for a very costly drug from the very beginning in and there has been no benefit found, rather the change of chances of So sacubitril/valsartan did not result in a significant lower rate of CV, death, heart failure hospitalization, or outpatient heart failure requiring, sorry, it has run into some error. Yes. And the safety and tolerability of sacubitril/valsartan in this AMI population was comparable to that of the AC inhibitor. So we don't find any justification of using ARNI in ACS situation. ARNI is full, no doubt, in heart failure situation. So ultimately, all these created a lot of hue and cry because there was a lot of hope and hype before the trial was published that ARNI will be useful in ACS also. So comment post-release. So ultimately, what do we have? Paradise MI, that was the trial with the ACS with ARNI, makes me, means the author, question the benefits of sacubitril/valsartan. Similar was the comment of other groups also. So coming to AC inhibitor now, the most important molecule in the management of ACS. So we know the basic things of ACS management are strong antiplatelet, usually a combination of antiplatelet agent or DAPT, known in short, high intensity statin, and revascularization either by thrombolytic therapy or angioplasty primary or a pharmacoinvasive therapy. So revascularization is the most important thing, and along with that, there are adjuvants like strong antiplatelet with or without thrombolytic or angioplasty stenting. Along with that, AC inhibitor is also indicated. I'll be coming to that. Another group, important group, is beta blocker. We have to wait for a day before using it, and that also differs in stable and unstable patients. And in some cases, we have to add the mineralocortical receptor antagonist also. So AC inhibitor post-MI trials, they're being done for a long time. Initially, some short-term data is available from consensus 2, GC3, sorry, ICS4, etc. And large-scale data is available from SAVE trial, AR trial, clinical heart failure. This was published in 1993. And after seeing the good result, I used this drug, ramipril, in a doctor who was admitted under me in the ICCU just after coming back from the conference when it was shown the results. And he survived, not only survived, his LV improved. So this is a very important landmark trial. We'll be discussing more about it. And TRACE, wall motion score, and EF, that was the point of choosing. Now, SAVE trial, survival and ventricular enlargement study. Here the result was captopril group showed 19% reduction in mortality and 25% reduction in recurrent MI. So it was conclusively proved that AC inhibition has got much higher advantage compared to the placebo group. Here the placebo was inactive. The cavity dilatation was reduced, so there is not only mortality reduction and recurrence MI inhibition, there was hemodynamic improvement also, and remodeling was prevented. These benefits occurred equally in patients who received lysis plus beta blockers and those who did not. That means this was independent of thrombolysis. At that time, reperfusion means were mainly thrombolysis, and these were independent of beta blocker. And so The follow-up period was 36 months. This duration of AC inhibitor trial, if time permits, I'll be having opinion from our colleagues also later on. Trace here in 1995, tenofovir was used in AMI with wall motion abnormality. They scored the wall motion index by echo, and they were randomized between 3 to 7 days. Nowadays, we do not talk about 3 days. We want to give it earlier. Tenofovir 1 milligram per day versus placebo were tried, and the results were very much important. 25% reduction in mortality. The mortality benefit was there. 15% reduction in recurrent MI. Recurrent MI prevention was there, and 20% reduction in SCD. That is very important finding. There was a significant reduction in sudden cardiac death. So long we thought that the beta blockers impart only the SCD effect, but here we find that the AC inhibitor have also SCD prevention. And we have talked about the large-scale randomized data like IC4, GC3, CCS1, etc. If you collate them, you will get a large number of patients. And captopril was effective in reducing 5-week mortality. Survival advantage appeared to be maintained in the longer term. And here the drug was started within 24 hours. So that taught us that you have to start it early, except of course in hemodynamically very unstable patient like hypotension, etc. We have to be a bit choosy about in whom to start and whom not to start. And which segment of the infarction is there affected, this is also important, because in the subset of anterior wall infarction, better significance in the difference of mortality was achieved. Here, the captopril group treated was found to have lower mortality, and the value was very much significant to the tune of 3.0. Now, I was talking about AIR trial, and they published in 1993, and here the very important AC inhibitor, ramipril, came into picture, and that was, trial was against placebo. So it was a randomized, double-blind, placebo-controlled trial, multicentric, acute MI with transient or persistent heart failure randomized between 3 to 10 days. That was done. Oral ramipril versus, and the dose was significant, 5 milligram PD, one has to remember, and follow-up period was 15 months. Ramipril dose showed 27% reduction in mortality and 19% reduction in the rate of MI and stroke. So you look into this thing, the stroke was also lessened. This is a very important finding. So relative risk reduction, 27% reduction in the cumulative mortality. You look into this red line, survival benefit is much more to the tune of p-value was 0.002, and this shows that ramipril was much more useful in preventing mortality. This study was extended, known as AIREX, and that was again those patients, some of the patients in UK, they were chosen from the multi-center in the follow-up group of the AIRE study, and they are again randomized double-blind placebo-controlled. Because the basic design of AIRE was like that, they were followed up for 42 months to 59 months. That means almost 4 to 5 years. And the beneficial effect of ramipril started early after MI with heart failure, and particularly with heart failure, and are sustained over 3 to 4 years despite discontinuation of the medicine. So that means if we start it early and continue for some time, long-term benefit is there, and relative risk reduction in mortality of 36% and absolute risk reduction of 11% was achieved. Here you find that the blue line versus the red line, survival is much better with ramipril with relative risk reduction at 36%. And p-value was again very significant. So ramipril was found to be useful not only in the short term, but on the long-term study. Despite discontinuation of ramipril study, initial benefit that was obtained was maintained. And long-term survival benefit in acute MI patients complicated by heart failure was survival study found, published relatively recently in 2021 to assess the long-term, that is almost 30 years after randomization, magnitude of impact on length of survival observed after treatment with ramipril target dose, as the initial AIRE study was 5 milligrams twice a day when compared with placebo. So duration approximately 30 years, one has to remember that. And primary outcome was life expectancy or all-cause mortality. Here, what was found, median survival time was 8.3 years, and there was extension of life by 14 months, 14 to 15 months. Survival curves cross at 15 years, rather around 14 years. So the benefit that was maintained for a long time, ultimately that equalized. Life expectancy was greatest at about 15 years. So here we find that they become equal, and life expectancy was improved with ramipril across all the comorbidity. This is again a very significant finding. So in case of diabetes, previous MI, history of heart failure, hypertension, angina, patient older than 65 years, and all these you find there is significant improvement, and that is known as life expectancy difference. So better result was obtained with initially ramipril given patients. So substantial survival gains with ramipril treatment for 15 years beyond the blinded treatment allocation. Overall, for every day a patient received ramipril, on average, his or her life was extended by a further day. That means it is something like marketing. Buy one, get two. 1 day of prescribe, he gets 2 days of lifetime extended. Relative risk of survival for patients with diabetes was increased by 54%. So again, I'm coming back here. Diabetes, 32 versus 50%. So that's a huge benefit, particularly in diabetic patients. And patients with diabetes, previous MI, previous heart failure, hypertension, and angina each benefited on average from ACE inhibition. Treatment with ramipril for about 1 year, when started early post-MI in patients with heart failure, results in a survival benefit which is sustained over many years and offers on average an extension of life or an additional 1 year. So concluding remark was treatment with ramipril for about 1 year when started early post-AMI in patients with heart failure results in a survival benefit which is sustained over many years and offers on an average an extension of life of an additional 1 year. Significant benefit. So going back to a review, what we do want to start ACE inhibitor within first 24 hours. That is our goal. But again, we have to look into whether patient is not having hypotension, or if the patient is already receiving ARB or some kind, the switchover should be gradual. Otherwise, start in day 1. And early introduction of aldosterone antagonist. At the outset, I talked about aldosterone antagonist also. Benefit is time dependent, should be started with 7 days. That means first step is an ACE inhibitor. I'm not talking about beta blocker because that is well known when to start. I'm not talking about the antiplatelet, etc. Not the talk of the day today, but aldosterone as a second phase, because we have to look into after AC inhibitor or beta blocker, whether the patient is holding his BP, pulse rate, etc., and whether failure is not being aggravated, dose titration should be there. So 7 days time period is allowed. And it is critical to titrate dose of medications, including ACE inhibitor and beta blockers, to optimal level in post-discharge time. So we have got initially to act quickly, then depending upon the patient's response. So we adjust the dose, and that is why patient management has to be individualized. The ACE inhibitor should be admitted within first 24 hours of heart failure patients, and patients with ejection fraction of 40 or less, that means heart failure with reduced ejection fraction. Heart failure patients of ejection fraction 40 or less, there is significant survival benefit conferred on the first day of treatment, and early titration and early initiation is important. And that is the message of this large-scale trial like SAVE, AIRE, TRACE, etc. Contraindications, one has to remember systolic blood pressure 90 to 100 less, and shock, acute kidney injury, and renal failure, drug allergy, etc. So be careful while starting the drug, but always there should be an attempt to start drug whenever possible. Now the guidelines recommendation, again, if we look into the 2020 EAC guideline for the ACS management, ACE inhibitor or ARB in case of intolerance of ACE inhibition are recommended in patients with heart failure with reduced ejection fraction less than 40, diabetes or CKD. So these are the complicated cases and high-risk cases, unless contraindicated. So again, a reminder about the contraindications, severe renal impairment, hyperkalemia, etc., in order to reduce all-cause cardiovascular mortality and cardiovascular morbidity. I'm skipping the usage of beta blocker, MRA, you know that. And after the 2020 guideline, I'm coming to the ACC AHA 2025 guideline, released in a few months only. In high-risk patients with ACS, LV ejection fraction 40% or less, hypertension, diabetes, or STEMI with anterior location. The location was, as I was talking about, documented in some trials, and oral ACE inhibition or an ARB is indicated to reduce all-cause death and major adverse cardiac events. And in patients with ACS and LVEF 40% less and with heart failure symptoms and diabetes. So here we have mentioned we get the hypertension, and here we get the mention of heart failure. A mineralocorticoid receptor antagonist is indicated to reduce all-cause death and MACE. Now, what about the non-so-high-risk patients? If you look into the third column, here you find that in patients with ACS who are not considered high risk, an oral ACE inhibition or ARB is reasonable to reduce a MACE. So here we are not getting much of mortality benefit, but MACE reduction is there. So it's now open for panel discussion. I think stopping the sharing part here, we'll be discussing the panel. I think all the panelists are present. Sapna?
Yes, sir. All the panelists are present.
Okay.
Yes, we can start with the discussion, sir.
Sapna, I'm Dr. Verma. Can I talk?
Yes, sir. Yes, Dr.
Hi,
Verma.
Dr. Arup. I have a small question to ask.
Hello, I can't hear you.
I have a small question to ask you.
Yeah, please
I go ahead?
put the one moment, doctor. Please put your question in the question box or chat box
Okay.
because the panelists are very much important. Let us get their opinion first in certain
Okay.
preset questionnaire. Then we'll be definitely coming to your question. The
Okay, sure.
erudite panel will be asking, I mean, answering your question. Thank
Okay.
you so much. And please have the trouble of typing it. So I think Dr. Ayankar is there. He's a very good interventional cardiologist and also an erudite speaker. I know him personally. So Dr. Kaur, can you listen?
Yes, sir. I'm here, sir.
To you, the question is, in the post-MI patient, post-revascularization, listen carefully, at what systolic blood pressure do you initiate AC inhibitor therapy? Number one. What is the starting dose do you recommend? And how do you uptitrate the dose? Over to Ankar.
So I think that's a very pertinent question. So as you said, it needs to be started as early as possible. So within 24 hours of the index event, if possible. So in such cases, we would generally want these patients to be off inotropic support, number one, and they should have a systolic blood pressure which should be greater than equal to 100 millimeters of mercury. The initiating dose is basically depending on what the blood pressure is of the patient. So if the blood pressure is a healthy blood pressure, we would start with doses of 2.5. Often if the blood pressures are very low, I mean, they're just about hovering around 100 or 90s. Often I start at low doses of Ramipril, that is about 1.25, and then I up titrate often within every 24 to 48 hours. And if not possible, maybe within the first follow-up visit in that is around 1 week.
Okay, thank you very much. Dr. Ganesh Shetty is there?
Yes, sir.
Dr. said, good evening.
Good evening, sir.
Will you switch the patient to an AC inhibitor if the patient at the time of MI was receiving the ARB for hypertension?
Yes, sir. I would like to switch. In fact, as you have presented most of the data, that ACE inhibitor has a good benefit in a post-MI patient, especially if the patient is having LV dysfunction. And according to Optimal, the benefit, in fact, Optimal says that ACE inhibitor will be preferable in comparison to ARBs in a setting of acute MI. So if there is acute MI, then ACE inhibitor will be preferred drug in comparison to ARB, and I would like to switch.
Looking into the recent ARB trials and also the guideline, do you think switching is essential?
Not really essential. The benefit is comparable, but still ACE inhibitor is preferable.
Okay, I got your opinion. Is any other panelist have got some different opinion? Do you, all of you like to switch over to ACE inhibitor or ARBs are equally good?
I personally feel, I mean, it's okay. So I personally feel ARBs are equally good, sir.
So this is the opinion of Dr. Kaur.
Yes, sir.
Yeah, thank you so much. Now, Dr. Partho Chaudhary, are you there?
Yes, sir.
Okay, can you listen?
Yes, sir,
Can
I
you
can
hear me?
very well listen.
Okay. So how early do you think an ARNI can be initiated in a post-MI?
Sir, if the patient is stable, suppose is not a volume overload, or if the patient is hemodynamically stable, then we can start as early as possible.
What? Start what?
ARNIs.
ARNI.
Yes, sir.
So do you think you have to switch over from AC inhibitor to ARNI?
No,
Because
sir.
why I'm asking this is that the two drugs should never be combined. That is AC
Yes, sir.
inhibitor.
Yes, sir. Yes, sir. Actually, we should give a washout period of 72 hours if we want to switch over from ACE inhibitors to ARNIs. If because of some reason, if you want to switch over from ACE inhibitors to ARNIs, you have to give a 72 hours time so that it can wash out to prevent angioedema and other
But looking
complications.
into the results of Paradise MI, do you think switching over to ARNI is important in ACS patient if he is already on AC inhibitor?
Sir, now recent data, they show benefits of ARNIs.
Okay, again, I am going to the other panelists. Are all of you the same opinion?
No, sir.
No, I slightly differ.
Yeah.
In post-MI patient with LV dysfunction, ARNI is negative trial. In fact, what you are mentioning, Paradise MI, it is a negative trial. So I would prefer ACE inhibitor because ARNI is obviously costly drug, and there is not much superior benefit in comparison to ACE inhibitor. So I would like to continue or initiate ACE inhibitor in comparison to ARNI.
When would you like to switch over to ARNI from AC inhibition? From AC inhibitor, not inhibition.
In MI patient.
In MI patient, yes.
In fact, I would not like to start ARNI. I would like to start ACE inhibitor. Although there is a specific
No,
criteria.
I am agreeing that you have started, but would you continue it indefinitely? Or
I mean,
may think of ARNI also.
so if I may answer, I mean, I just have a viewpoint here. So I think this is a very gray zone. I don't think there are very great guidelines for this, but the intention is very pure out here. So ACS is a very difficult subset in the sense that once you revascularize, often these LVs improve. So which is why I think often we would want to wait for about a few months, keep these patients on ACE inhibitors. If the LVs improve, I think they should generally be left on ACE inhibitors alone. However, let's say this patient continues to have a low LV beyond 3 months and the LV does not improve. I think they become a subset of chronic heart failure patients. So when it comes to chronic heart failure, I think the data becomes more stronger in terms for ARNI.
So what duration would you wait for? Which after what? How many months?
So there is no right answer to this question, but however, in current practice, I would generally say we would wait for about 3 months for LV recovery.
Fine. I think whenever you find a case of LVEF 40 or below, just don't jump into ARNI. You can treat the patient, let him get stabilized. After 3 months, you find he has gone into chronic heart failure phase. He's not, and that has to be clinically symptomatic and with signs of heart failure. So not only ejection fraction is low, but clinical evidence of heart failure is there. Then you may switch over to ARNI. And Dr. Verma?
Yes.
Yeah, thank you for being with us. Post-revascularization, if you find LV systolic dysfunction but without clinical heart failure in your patient, will you put the patient on ACE inhibitor or ARNI?
Absolutely. Now, even I want to come in for the last discussion also, like what Dr. Kar has said, that whenever there's a post-MI patient, right, we should wait for 3 months for the acute thing to settle down before chronic stage, what we usually call it. Because all the trials, if you talk about paradigm or whatever trials, what we talk about, they tell the supremacy of ARNI after in the chronic heart failure stage. But like Paragon has failed to show supremacy, that's why in acute condition or acute MI, we may not stop ARNI. Now coming to your question, post revascularization, if EF is low, definitely I'll try to put him on ARNI because even in asymptomatic patient, we have shown benefit with ARNI over enalapril.
Here my question would be to you that suppose you started with LVEF below 40 and it is remaining below 40 with AC inhibition. Suppose he is not having any clinical heart failure symptom or sign, only low ejection fraction. Would you like to switch over or would you?
No, I'll switch over, sir. I'll switch over because in paradigm also it has been shown that if you switch over, the EF improves. And there's only ARNI which have shown improvement in ejection fraction. We have no trials with ACE inhibitors to show improvement in heart failure ejection fractions post starting it. But ARNI has shown improvement, so I'll definitely switch him over to ARNI.
Fine. Now, another question to Dr. Kaur and Dr. Sheth. Do you consider NT-proBNP as a deciding marker for choosing ARNI over ramipril? We are talking about so long clinical manifestation. Now we have come to NT-proBNP as well.
Oh, in my opinion, I will not use. As as the guidelines say that NT-proBNP should not be used as a marker for improvement. So I will not really monitor patient with NT-proBNP, but yes, symptom is important.
Dr. Kaur?
So I think the diagnosis of heart failure, sir, is a clinical diagnosis. It does not really require NT-proBNP to make a diagnosis. So if the patient has symptomatic heart failure in the background of LV dysfunction, and he's between NYHA class 2 to 4 and an EF of less than 40, I think he would become eligible for heart failure therapy. It is not based on NT-proBNP. So you're right. So I wouldn't generally go by just the NT-proBNP.
Thank you both. And Dr. Chaudhary and Dr. Verma, your next question is, will you start an AC inhibitor in all the patients with ACS, whether revascularization procedure was performed or not, to get the mortality benefits?
Sir,
Yeah.
it is not to done with revascularization. It is basically irrespective of whether you did lysis or you did revascularization. It is basically it prevents ventricular remodeling. So basically, it is the LV dysfunction which matters most for these ACE inhibitors. So
yeah. And trials have also shown that
yes.
Whether revascularization has been done or not, AC inhibition are useful. Dr. Verma?
Yeah, same. I also on the same page that whenever we have LV dysfunction EF less than 40, ACE inhibitor should be given irrespective of the revascularization is done or patient is medically managed or if there are lesions or not, because we are basically targeting cardiac remodeling and neurohormonal blockage rather than doing anything with the coronaries.
Okay.
I
I
would
am
like to add
making
here.
an extension of this question. Suppose a patient is having better ejection fraction, like 50 or more. Would you like to use AC inhibitor in those patients with post-ACS? 50%
Sir,
or more,
I would
no
like to
clinical
answer
sign of
this.
heart failure.
See, there are 3 indications in ACS patient for starting ACE inhibitor. Number 1, LV dysfunction. Number 2, hypertension. And number 3 is diabetes mellitus. So it is irrespective of revascularization. And for your second question, it is again, if the patient is having hypertension, diabetes mellitus, then ACE inhibitor should be continued.
Okay. I think
Yeah, I also.
here the issue comes. I'm just giving a statement that in those high-risk patients, you have mentioned the risk features like diabetes, hypertension, low EF, etc. There is mortality benefit as well as morbidity benefit.
Yes.
And MACE reduction. But do you think it is not at all useful in other groups, not so high-risk patient?
Obviously, it is
whole
beneficial.
panel can respond to this question. That is whether AC inhibitor, if it is not contraindicated, if it is tolerated by the patient, or ARB, if it is tolerated by the patient and there is no contraindication, even if their ejection fraction is higher, is not hypertensive, non-diabetic, would you like to continue?
Yes, sir, we would continue.
Yes, I think that will help in reducing MACE. That means what is our usual understanding is if the patient is more high risk, benefits are more robust, but even the patient's risk is not that much, still they are useful in secondary prevention. So thank you for answering all these questions. Now I open the question box for the audience. Is there any, do you find? Sapna? Hello? Is Sapna there?
Yes, sir. Yes, sir. Thank you so much for
You
the
find
wonderful
any question in the
discussion.
question box?
Yes, sir. So we have received some questions from the audience, and I posted them in the chat. I would kindly request our panelists and sir, you to provide the insight.
And there was an initially one question. I am not sure whether the question was from the panelist or from the audience.
Yes, sir. It is
So
all
can you please
all
repeat your
panelists in
question?
this link. So we are all panelists and the delegates, sir. Dr. Gaurav Verma has posted a question.
Hello.
Yes,
Okay, Dr.
Gaurav.
Verma, you had a question from your side. why they have been given equal importance, AC inhibitor and ARB in ACC 25 guideline. So anybody would like to respond this question? Panelists, can you see the question box or chat box?
I mean, I'll take a chance at it, sir. So the thing is this, that when we say that ACE inhibitor is better than ARB, it is purely because of the burden of evidence. And it is also not just burden, it is the quantum of evidence that is available for ACE inhibitor in post-MI settings. If you look at studies like the AIRD study, which has been followed up for 30 years, I think we do not have similar studies with ARBs. However, I think given the fact that with ARBs being working in both the diabetic, renal, post MI field also, I think as of now it's the evolving evidence almost puts it at par, and often it helps us in transitioning to ARNI therapy very easily, which is why I think it is becoming easier to prescribe.
Yeah,
No, but
actually,
Dr.
RAS,
Arup, Dr. Arup,
in the RAS group,
hello, Dr. Arup, Dr. Verma here.
AC inhibitor came first, and they had lots of trials, and the accumulated patient year-wise data have become more robust. But ARB is also quickly catching up. Maybe in future they will be of equal importance.
No,
The
Doctor.
Americans are a bit ahead in this thinking process. In the 2025 guideline, they have already given equal weightage to either.
Dr.
And
Arup. Hi, Dr. Verma here.
Yes, please.
Yeah, like in your talk also, all the trials what we have talked about in post-MI setting, like AIR, SAVE, consensus, everything have been done or superiority have been shown with ACE inhibitors, right? I don't know much about the trials with ARBs, any of the ARBs, valsartan or any telmisartan in post-MI setting, which have shown a superiority or even equal, MACE reduction. So, but still the weightage have been given to both the things equally. So I still don't understand this thing.
Yeah, so your opinion would be give AC inhibitor. If it is not tolerated, then only switch
Absolutely,
over to ARB.
like it was there before.
So you are of this a bit, though you are very young, your opinion is a bit consistent with the older generation. Look into the benefit. Fine. This can be one approach. There is no harm in it. At least the patient is not being done any harm. So primum non nocere, that is our dictum. So from that point, you are quite justified. So question from the audience. In Indian hypertensive patient with multiple comorbidities, how do you stratify risk to decide between initiating therapy with an AC inhibitor versus an ARB? So the question, I think it is only hypertension alone. It's not a question on ACS, but yes, you can, any of our colleague could respond to this. I'm repeating the question in short. In Indian hypertensive patients with multiple comorbidities, how do you stratify risk to decide between initiating therapy with an AC inhibitor versus an ARB? Anyone would you like to respond?
Hypertension, sir, with multiple comorbidities, I think we have now a lot of data with ARBs at the moment. I think where ARBs are definitely, quite well suited. I think this would be a clinical equipoise as far as I'm concerned. I think the decision to start either ACE or ARB in this case would be finances often, and the decision that often ACE inhibitors are cheaper than ARBs.
And I think the question initially started with how do you stratify the risk? There is no difference. The
There is
risk
no
scoring
difference.
method, they
Even
take
the
up.
guideline, hypertension guideline suggests that ACE inhibitor and ARB can be equally useful in this
That is
situation.
accepted
So
in
there's
the
not much difference.
hypertension subset. Both are same and similar, but risk stratification remains for the anything, any drug, any lifestyle intervention, any prognosis. Risk scoring system remains same. So with multiple comorbidities, maybe he will be going into the red zone, not green or yellow either. So in those cases, AC inhibitor, ARB may be equally indicated. It's your choice which one to continue. And I would request here my colleagues that in case you are prescribing ACE inhibitor, that there may be certain increased incidence of cough, and in that case, he should come back to you rather than going to an ENT specialist or a chest specialist or discontinuing the drug indiscriminately. So prior warning and counseling would do a lot so that you can switch over to an ARB in due course of time. And thank you for asking this question. Another question is, how do you tailor RASI therapy in Indian patients with overlapping comorbidities like metabolic syndrome, early nephropathy, and LVH? Do you see a role of one class over the other in targeting organ protection? Dr. Shet, would you like to respond?
ACE inhibitor has a good data regarding improvement in the renal function as well, delaying the kidney progression, disease progression. So if the patient is having CKD, ACE inhibitor should be used irrespective of the creatinine. The main hurdle is potassium monitoring as well as correction. So if the patient is having nephropathy, then with hypertension, then ACE inhibitors should be used.
So he has asked about multiple issues. Metabolic syndrome, early nephropathy, nephropathy part you have covered, and LVH. So do you think in LVH regression, ACE inhibitor ARB has got some different role?
I don't think so. In fact,
I think
hypertension control is important, and LVH regression is truly speaking not really common.
Okay. And,
So,
the metabolic
irrespective of the
syndrome?
drug you use, metabolic syndrome, I'm really, I'd suggest Ayan to take this question about metabolic syndrome, if you want to say anything.
So your, I mean, what I get in short, that from your standpoint, in the cardiorenal syndrome or CK syndrome or CRM syndrome, whatever the combination or permutation is, better to go for what? ACE inhibitor or ARB?
ACE inhibitor.
Okay. And for stroke, it is not
For
mentioned here.
stroke, again, ACE inhibitor is better.
Okay, fine. So if any of our panel has got any difference of opinion, you can raise your hand and start talking. Otherwise, I'll be going back to Sapna to end the session.
Hello. Hi, Dr. Arup. Dr. Verma
Yes,
here.
sir. Dr. Verma, boliye.
Yeah, I have just a small query. When we talk about the different overlapping syndromes or comorbidities, for me, diabetes and metabolic syndrome comes at the topmost. Even if the patient has LVH, we are not going to regress it so soon. So for me, if there's a metabolic disease or uncontrolled diabetes, that I'll be trying to treat or initiate with a RASI first with ACE inhibitors. What is my opinion.
Okay, thank you so much.
I would suggest, sir, that ACE inhibitors actually tend to reduce microalbuminuria better than ARBs. I mean, it's a little less known, but I mean, I think most of our nephrologists tend to write a lot of ARBs I see upfront. But typically, if I'm not wrong, the data is more in favor of ACE inhibitors.
Okay. In both the last questions, Indian, that has been highlighted. So I'll go to Dr. Sapna in this regard. Do you think that the price becomes a factor in choosing between ACE inhibitor and ARB?
Yes, sir.
Sapna, what is the price of ARB and ACE inhibitor when we compare the equivalent dosage?
Surendra, can you answer that about the price?
Mr. Surendra is there. Can you reply to this question? Price equivalence? Because I'm not very clear. I have not consulted the price chart.
Sir, can you hear me? Yeah.
Excuse me, sir.
So, sir, if you
Yes.
see the price difference between the ASN versus ARBs, so usually the initial dosage of the Ramipril, it is under the anilium. So dosage is very low. 5.5 rupees is what starting price for any ACE inhibitor, as it comes under the government control price. So it is lesser than the ARBs, what we can say as we are concerned. The 2.55 mg are costing very less compared to the ARBs.
Thank you so much. Perhaps Oyan also gave his opinion regarding the choice. What is your calculation about choice? I mean, calculation of price regarding the choice, Oyan?
Well, two things. One is ACE inhibitors is definitely cheaper, and you have these combinations with ACE inhibitors and beta blockers, often ACE inhibitors with calcium channel blockers, which are very effective. I mean, so compliance is better with patients, and you have the best of both worlds. So if you look at AIRE studies or studies from a little older era, I mean, an ACE inhibitor and a beta blocker together, they would reduce mortality significantly. And I think there are two drugs easily available most of our population can afford, and I think it works very well.
Yes, I'll be going to my own comment regarding another issue which is very often overlooked. That is patients with borderline renal function who are prone to hyperkalemia. Both ACE inhibitor, ARB, beta blocker, and MRA, all are having a tendency to raise potassium. So this combination, one has to be careful. Often the beta blocker, in the role of beta blocker in raising potassium is overlooked. We have to be careful about that also. With these things, I thank you all the panelists, all the audience, and all the organizers. And over to Sapna for her own remarks.
Sure, sir. So we are now at the close of what has truly been a meaningful and enriching scientific program for all of us. So, sir, before we conclude, it is only right to pause for a moment of gratitude. First and foremost, my sincere thanks to our esteemed, wonderful moderator, Dr. Arup Das Biswas, for steering today's session so thoughtfully and for leading such an engaging panel discussion. A heartfelt thank you to our expert panelists, Dr. Ayankar, Dr. Gaurav Verma, Dr. Ganesh Seth, and Dr. Partho Chaudhary for so generously sharing your wisdom and expertise with us. Your insights have added immense value to the program. To our wonderful audience, thank you for your time, your engagement, and your contributed love for the Cardio Colloquium initiative. Your presence and participation are what makes these programs truly alive. On behalf of entire MCure, I also extend my deepest gratitude to every member of our sales, marketing, and other team members. It is your tireless work behind the scenes that makes program like this possible. Finally, to everyone here, thank you for being part of this journey, not just today, but throughout the path that has brought us this far. Each one of you has played a role in shaping the success of the program, and for what we are truly humbled. With that, I wish you all a pleasant evening, good health, and continued success ahead. Thank you once again.
Thank you.
All
Bye.
Thank you
sides.
so
Thank
much.
you.
Thank you very much. Have a good night
Thank you.
and great tomorrow.
Good night, sir. Good night, everyone.
Thank you, sir. Good night, sir. Bye-bye.
Good night. Bye.